Welcome everyone for joining me and Leona from the Burnaby Division of Family Practice in my talk about what we should know about diabetes. Of course, I don't expect everyone to know everything I'm going to talk about. That's why you're here. But there's a lot of misconceptions about what diabetes is. So hopefully I can explore the common myths and clarify what diabetes is, how common it is, and why it's actually important to all of us because it will either affect ourselves, someone in our family, or a good friend. And it's good to have a good understanding and to support the people around us that need our support. We can't do any of this alone as doctors, healthcare providers, as patients, and as family and friends of patients as well. I'd like to reintroduce Leona to you. So Leona is the acting executive director for the Burnaby Division of Family Practice. So she'll fill you in on some resources that are provided by our Burnaby PCN Primary Care Network and the Burnaby Division.
Great. Thank you, Dr. Wong. Happy to be here with everybody on this beautiful night. I was just commenting to Dr. Wong, I've got the moon right out my window here. So if I look up, you'll see that I'm distracted by nature outside. So welcome. And so I'm going to pop some resources into the chat. If you've been here before, you'll be familiar, but you never know, things do get updated. We're going to do, I'm going to put the Empowering Patients page. We have scheduled all of our talks to April of 2025. So take a look at the topics and registration links are already there. So please feel free to register for any ones that you're interested in. I'll also put in our other resources page, which will include downloads of Dr. Wong's presentations for all of our talks, a key points document, which is just an information sheet where Dr. Wong has highlighted all of the main points for each topic. And Dr. Wong just had an article in the Burnaby Now on November the 10th. So just a link through to that. So those are always really helpful articles that he writes. And we're really grateful that the Burnaby Now shares those in the paper and online. I'm going to share, as Dr. Wong mentioned, about our PCN, or Primary Care Networks, which is our work that we do with the Fraser Health Authority, the city, and many community partners. So there's many resources available here in Burnaby via your family doctor, whether you need foot care or you need some counseling or something like that. If you're fortunate enough to have a family doctor here in Burnaby, you could have access to those resources. And then there's other community resources that are available now through the PCN. We do have another free education program called Doc Talks, and those are other doctors in Burnaby who come together and provide information on different topics like COVID boosters or those types of things. So I'll pop that into the chat as well. And what else do we have? We have our monthly checkup newsletter. It's a community newsletter where we vet resources, local news, social media content, what's going on in the PCN. So any updates, current updates around the PCN, anything where our doctors have been featured. Our Burnaby doctors have been featured in the media, such as Dr. Wong, Dr. Burinder Narang, who's quite regularly on Global News. He's one of our doctors. And then and then I'm so sorry, if you're looking for a family doctor in Burnaby, I'll put a link to the patient attachment program, which will then link you to the Health Connect registry. It's now done, the waitlists are now done provincially. It's a one-stop shop where you can register for yourself to be on the waitlist for a family doctor. If you live in Burnaby and would like a doctor in Burnaby, that information does come to our staff and they will connect with you. So that's it for all the resources. I will, as Dr. Wong gets started, I will pluck those into the chat. Please feel free to reach out if you have any questions. And when we're at the end, I will, when I close down this session, there will be an 8-question evaluation. So please take a moment to complete the evaluation, and the information is really helpful for us. So, and then Dr. Wong will probably speak to our next talk, which is on December 19th, and that's on emotional wellness and resilience. So that will be a good one as we go into the holidays. So Anyways, enjoy Dr. Wong. I'm here if you need me. Please pop your questions for him into the chat, and he always makes some time to answer them at the end of the session.
Great. Thank you, Leona. Thanks for updating us, and thanks for all you're doing for our community through the division and all your other activities in our community. So the Burnaby Division of Family Practice that Leona's been talking about is the nonprofit association of the family doctors that serve the Burnaby community. And the PC in our primary care network is how we work together in all the neighborhoods of Burnaby with the rest of the team. Like there's so many organizations, including Fraser Health, and so many wonderful nonprofit associations that look after your care. So family physicians through our association are working together with all the partners to look after everyone in our community. And you're an important part of that primary care network as well. So what you can share with your neighbors and reaching out to your neighbors so that they're not feeling isolated, and sharing anything you find useful in any of our talks or resources you hear about through the Burnaby Division or the primary care networks, please share that with people that you know that might benefit from them. So that's our website, divisionspc.ca Burnaby, or you could just Google Burnaby Division of Family Practice. And we always start with why we're here. Often ask myself that sometimes, but rarely at the office, because I love doing what I do in primary care and looking after the patients that I've known for so many years, and they're part of my life, and I'm a big part of their life too, as partners in your healthcare. So of course we care about our patients, but as family doctors, as all the activities of the Burnaby Division show, our doctors care about our whole community as well. And that's a big reason why I'm here, giving back to the Burnaby community in which I grew up since elementary school. And we're all contributing to the future of people that come after us and the future of our community by kind of creating and building networks that are going to last beyond our lifetimes that we're hoping for. And also just that goodwill and caring and the compassion we give to one another is passed forward to others as well. So we care about our patients and we care about our community. This topic is really close to home, really close to home. This is a family picture of my dad's family before he was born in 1930 in Cumberland, which was a small town where close to a coal mine, I guess over 120 years ago. So my dad was born in 1930, and this picture was taken probably a few years before he was born. So it's a picture of his older brother, Uncle Benny. That's the little boy there. And my aunties, Auntie Lila and Auntie Lily, with my dad's father holding the baby, and my grandmother. So the only grandparent I knew was actually my grandmother, because my other grandparents, both sides of the family, had passed away when both my mom and dad were children. My mom lost both her parents in Vancouver when by the time she was 9 years old. And my dad's father passed away when my dad was only 5 years old. So he hardly knew his father at all. So we only knew Nyan Nyan, my grandmother. But I didn't get a lot of time. I wish I had a lot more time with her. So she died at age 62 when I was still in elementary school. And she died at St. Paul's Hospital from kidney failure, which is one of the complications of diabetes. We had far fewer things to use to treat diabetes in those days. And certainly people know a lot more about it today. And that's a big reason why we have to be proactive for ourselves, but also as healthcare providers, so that we can prevent the tragedies of the complications of diabetes, which we'll go in detail, but also the loss of life and losing our loved ones. And that so many years, because 62, that would be a young age to pass away. So many more years she could have had in front of her. So today we'll talk about just a framework of how to think about our health beyond just healthcare. We'll go over some of the common myths and then counter that with the facts about what diabetes is and how to determine if you are at risk and if you should be tested for diabetes and how often you should be. We'll talk about the important things that people who do have diabetes, what they should monitor. And we'll talk about the basics of healthy eating for diabetes, the value of exercise, and we'll close with just a little framework for helping you to achieve your personal goals, whether or not that relates to diabetes. Because patients that have diabetes, as doctors, as healthcare providers, we really overwhelm them with information about what they can or should eat, how much they should exercise, what tests they need to do. It can be quite overwhelming. So one of the purposes of this talk is to talk about the basics and the framework, but it's still a lot of information. That's why we have the key points handout for you to refer to, and other resources that you can turn to that I'll mention during the talk that provide much more detail than what we can cover today. So just taking that big picture look, what is healthcare? Well, part of it is all these things that people do in their white coats and scrubs. And it's the acute hospital care that we see on TV, like Chicago Med or ER or Grey's Anatomy. That's a small portion. A lot of it is in the community, what your family doctor does, what your home care nurse does in the community, and all the outpatient clinics that support people that are managing chronic conditions, and all the work of our partners in the primary care networks as well. But who is the one that provides most of your health care? And the hint is he or she is probably not wearing any of these kind of scrubs or uniforms. It's actually you, of course. You are the most responsible person that's looking after all those things, your lifestyle, your exercise, doing those blood tests, monitoring yourself if you have to check your blood sugar and your blood pressure, and taking medications if you've been prescribed medication. So it's all up to you. And as healthcare providers, we need to give you the support to help you achieve your goals and to help you get access to the resources you need whenever you need it. But one of the keys is really that information that we try to convey to our patients individually and then to the community, like this talk, one of the Empowering Patients talk, just to raise health literacy or knowledge so you know what's available, how to communicate with healthcare providers, how to get the care that you need. So I really believe that real healthcare is that self-care, that you're the most important person on the team. You're the quarterback. We're there as your advisors and your support and navigators for sometimes a complicated healthcare system. And the best predictor of your future health, at least those things under our control, which are plenty, are the habits that we practice every day. So that's an overriding theme in all my Empowering Patients talk. So the 4 foundations of your own care of yourself include what you eat, what you put into your body, as opposed to the unhealthy things we put into our bodies, like alcohol, cigarettes, or recreational drugs. What you do, physical activity and rest. How you feel, emotional well-being, which is the topic of our next talk, just to get you all ready for Christmas and those often emotional reunions with family members, particularly in-laws. And finally, how you connect, healthy relationships, which also ties in with all of our health. So the 4 foundations of our own self-care are what you eat, what you do, how you feel, and how you connect. So these are ongoing themes and topics in our Empowering Patients talks. So what do you need for good self-care? Well, you need a good base of knowledge. And that's why we have these talks, because I realize that most of people's exposure to healthcare information is quite biased because you didn't all go to medical school like I did. So a lot of our knowledge actually comes from people selling things to you. Actually, my office associate, Dr. Gopal Rar, was just mentioning that a patient was asking about this new drug to treat his back pain that he read about in a big feature in the newspaper. And obviously it was someone trying to sell something. You have these nice big, nicely laid out pages with convincing information about some new treatment. But of course it says this is an advertised supplement for your paper. So often it's something that someone's trying to sell you. Often the news that you see on TV, on the news in the evening, is something that's sensational, but it doesn't give you all the knowledge that you need to know to look after yourself or the next steps or how it applies to you. So this is our objective, non-biased information as far as we can. You need that professional and peer support. So that peer support are other people in your community that we can connect you to that are actually dealing with the same thing. So often, for example, in mental health, people get a lot of benefit in learning ways to manage difficult emotions or manage difficult thoughts through group therapy, meeting in groups and learning skills that are run by healthcare professionals or counselors. And likewise, people with diabetes and other chronic conditions benefit a lot from the self-management groups that are led by nurses and dietitians in our community as well. And finally, planned care, knowing that with your conditions, how often you should be seeing the doctor, doing blood tests or other ways of monitoring your condition. So sometimes that can fall by the wayside if you don't have a regular family doctor, or situations like the pandemic, where we didn't see our patients, or you didn't see your doctor as regularly, or maybe even years before you actually saw him or her in person. And I would define health not so much as the absence of disease, but uh, and healthcare, of course, not being just the treatment of disease. I think it's much more proactive and positive than that. I believe that every one of us, you and I, we each have a unique potential in this life. And it's our duty to realize that potential and to help others achieve theirs. So, I serve my mission statement by helping you and helping my patients and my colleagues as well. So our positive potential isn't perfection, but it's guided by your personal values, what matters to you. And again, what we need for good self-care, we need that knowledge, and that planned self-care is healthy eating, physical activity, medications, and monitoring. And we'll talk about how that applies to diabetes as well. So let's look at some of the most common myths about diabetes. A lot of people don't think they need to worry about it. You may have heard the news, like on CBC today, talking about the epidemic and rise of diabetes and the difficulty that people have in many other countries in getting access to care and getting medications to treat their condition. So, diabetes is really common, but we'll let you know during this talk if you need to worry about it and assess what your risks are and what your next step should be. A lot of people think it's just about sugar, so avoiding sweets and sugars and sweet drinks. Well, that's part of it, but there's a lot more to it as well. And a lot of people think that it's people being overweight or eating too much sugar, which is the cause for diabetes. So that's only a partial truth. But if you listen to the news today on CBC, you would think that diabetes is caused from eating too much and increasing obesity, and that's why there's an epidemic. But that's only part of the answer. And the other myth is that a lot of people think that everyone with diabetes is going to end up taking insulin, and that they have to check their blood sugars and poke their fingers 8 to 10 times a day. So that's not the case for most people. In fact, most people with type 2 diabetes do not need to do their monitors every day or to do it 8 times a day. And the majority of people with type 2 diabetes are not on insulin, and many can go through their whole life without requiring insulin. So those myths that we're going to explore one by one. First, do you need to worry about diabetes? Diabetes is really common. In Canada, it's a little bit under 10% of the population has a lifetime risk of diabetes. So 10% of adults, 1 in 11 adults. And that risk increases as we get older. As we become less active, and if we gain weight, that risk, which is a genetic risk, increases. Incidentally, if you listen to the news as well, Canada at 1 in 11, that sounds very high, doesn't it? But it's one of the lower rates compared to other countries around the world. It's actually a lower rate than you see in the United States as well. But if you, like I, have one parent that's had diabetes, your lifetime risk actually goes up to 40%. So from a little bit less than 10% to 40% of one parent has diabetes because there's a big genetic factor. And if both your parents had diabetes, then your lifetime risk is at least 50%, like 1 in 2 chance that you'll develop diabetes. So if you do have any family history of diabetes, you are at risk and you should be checking regularly. And you can discuss with your primary care provider of how often you should be doing that. And we'll talk about the tests we do to diagnose diabetes and to monitor. So we should all be aware of it because it's super common. And for some of us, it's a very high chance that we'll develop diabetes. Myth number 2, it's all about sugar. Well, diabetes is a problem of more of metabolism, how our body converts food and sugars and other proteins that we absorb into energy, and how that energy is being used by our cells. So it's more of how our body converts that food into energy. So what actually happens is that the insulin that our body produces through the pancreas, our bodies become resistant to it. So it doesn't control or manage the sugars as well. So it doesn't get them into the cells and used for energy. And that results in a variety of side effects affecting almost every organ of the body. So glucose is an important source of energy, and diabetes can affect every cell in the body, every organ. From the heart to the kidneys to the brain to your blood vessels to the nervous system. And if we don't get diabetes under good control, which actually should be the minority of patients with all the resources we have. So if you work with your healthcare team and we're right on top of things and we're listening to you and looking at obstacles to the exercise and the diet, we should be able to control it without these complications that we well know that you're at increased risk if we don't control the diabetes. The risk for heart attacks and strokes, the risk of losing sensation or having chronic pain in our extremities, especially the legs and the feet. The problems with circulation to our extremities and leading to common infections of the skin or skin ulcers or even amputations when there's a bad infection or poor circulation. The risk of blindness due to blood vessels growing in the back of the retina. The risk for cataracts and glaucoma, diabetic foot disease, and kidney failure or disease. So because it affects all the blood vessels in the circulation, all the cells of our body, then there's a variety of complications that we have to watch out for. And as I mentioned, my grandmother lost her life prematurely due to a complication of diabetes involving the kidneys. And myth number 3, that it's just from being overweight or eating too much sugar. So most of my patients where they have a diagnosis, new diagnosis of diabetes, they don't consume extra sugar. They don't drink juice or pop or eating candy or candy canes all the time. So there are 2 basic types of diabetes. One is type 1 diabetes, and that's from the get-go that the pancreas is not producing insulin anymore. And if you don't produce that insulin, it doesn't matter how good your diet is, the sugars will be out of control because you need that insulin for that metabolism. So people with type 2 diabetes, so often children that are diagnosed with diabetes at a young age without any obesity, often it is this insulin dependent type 1 diabetes. And sometimes it can come from some unknown inflammation, like an infection of the pancreas, or a viral infection could affect the pancreas, cause inflammation, and it could affect the pancreas so that it doesn't produce the insulin anymore. So that an adult could just suddenly have high blood sugars after a viral illness, and then have type 1 diabetes. But the more common type of diabetes that's more commonly inherited is type 2 diabetes. And it doesn't start off as insulin, a lack of insulin from the pancreas, but it's our body becomes resistant to its own insulin. It doesn't respond the same way. So that's about 90% of people with diabetes. It's this type 2. It's generally hereditary, and the cells of the body don't metabolize the same way and are resistant to that insulin. So we call that glucose intolerance. So it's not just sugars, but it's all carbohydrates like starchy foods, which are converted into sugar. So consuming large amounts of those, or even normal amounts in a regular diet, can cause a rise in blood sugars because our body's not using insulin to control that metabolism. Myth number 4 is that everyone with diabetes is going to end up on insulin and having to check their blood sugars throughout the day. So sometimes diabetes will progress in spite of good management. There may be some point in the future someone needs insulin, but only if the numbers are way out of control do we start that near the beginning of the treatment for diabetes. Fortunately, we have a variety of other medications that we can use long before insulin becomes necessary. Yeah, so as I mentioned, type 1 diabetes is where they definitely have to use insulin because of the lack of insulin produced by the pancreas. And they require careful monitoring, either doing the monitor that they do the finger pricks, but you've also probably seen people with the monitors that are done continuously, like a little uh, circle that you might see on their deltoid. You might see people at the community center in the swimming pool even wearing those continuous glucose monitors like the Dexcom. And again, with type 2 diabetes, most people don't need insulin with the onset of the condition, and they usually don't need the frequent glucose testing throughout the day, although it's very useful just to see how a change in your diet can help you control your sugars better. Regular exercise, for example, 30 minutes every day and more frequent regular meals with what you'll learn about as low glycemic index foods are essential. So low glycemic index, I'll explain later, is the ability for a food to make the sugar go higher. So high glycemic index foods like processed foods like white bread tend to make your blood sugar go up higher than whole wheat bread, or brown rice has a lower glycemic index. So eating the same amount and same number of calories of that food will prevent the sugars from going as high as the high glycemic index foods. So the choices of the starches can make a big difference without you necessarily going hungry. And as I mentioned, there's a huge variety of medications that have come out just in the last 6 years that we can use. Before, we just had a handful of medications that we could use before needing to use insulin. But fortunately, there's been a variety of new medications. And one of them you probably heard of already. It's used for weight loss. That's Ozempic. But there are a variety of pills and capsules, oral medications that can be used. Ozempic happens to be a once-a-week injection that people use primarily for diabetes, but one of its other effects is to reduce appetite and to cause weight loss. That's quite significant as well. And that fifth myth, everyone with diabetes gets complications. So I have a large practice, so I have over 200 patients with diabetes, and very few of them, a small minority, are having complications. But those complications could be really severe if the blood sugars are not well managed over a lifetime, including toe amputations. So I've had 2 patients in the past month that have had to have toe amputations because of the effect of the high blood sugars on their circulation and the nerves going to their extremities. So the good news is that with careful self-management, with the support of a healthcare team, most of these complications can be avoided. And professional support and education really will enable you to be the best manager of your healthcare. So what are the symptoms of diabetes? So most people that we just diagnosed with borderline diabetes probably won't have any of these symptoms. It's usually where the sugars have been very high for a number of months or even years that people get these dramatic changes. So unexplained weight changes. So it could be unexplained loss of weight, 10 or 20 pounds for no reason, or it could be unexpected weight change, especially around the abdomen. So either could be a symptom of high blood sugars or diabetes. Number 2 is excessive hunger. We call it polyphagia. Like you just can't get enough food because you're really craving and consuming a large amount, and that would cause an excessive weight gain. And then the medical term polydipsia relates to excessive thirst, just being super, super thirsty all the time. And then finally, polyuria, excessive urination. So as you get older, men and women urinate more frequently, but it's usually small amounts. So with polyuria from high blood sugars, that sugar will pour out into the urine, and it's usually large volumes of urine, just like almost like a fountain. So people can get really dehydrated and lose weight that way. Polyuria. Yeah, like a fountain. Nice steady stream, but a huge volume that your body is producing just to get rid of that sugar. So unexplained weight changes, gain or loss that are unexplained, excessive hunger, excessive thirst, and excessive volumes of urination. As I mentioned, most new cases are diagnosed before these dramatic symptoms appear. So So on the outset, on average, 1 in 11 people will develop lifetime risk of diabetes. But if you have a family history, as I mentioned, greatly increases the risk. As I mentioned earlier, one parent with diabetes, 40% risk over a lifetime. Two parents with diabetes, 50%. If, as a woman, you have a history of having diabetes in pregnancy, that is a great suggestion that you're at higher risk in the future. There's a condition called polycystic ovary syndrome. So the symptoms would be gaining weight, growing extra hair around the chin for women, having very irregular periods, long stretches and skipping periods, usually starting in the teens. And untreated and unrecognized, then that could lead to increased risk for diabetes, high blood pressure, and high cholesterol as well. And something very similar and sometimes related in the same people are metabolic syndrome. So that's a common condition in my in-laws because both my parents-in-law had metabolic syndrome and diabetes. So it's a constellation of higher blood sugars and diabetes, higher blood pressure, abnormal cholesterol, including triglycerides and the bad cholesterol, low levels of the healthy HDL cholesterol, and increasing abdominal fat. So it's actually an inherited condition where you can get this constellation of symptoms, and those people are also at genetic high risk for diabetes. But the good news, if we recognize it early, we could treat it early and avoid the complications, sometimes even avoiding diabetes being diagnosed. And people of Aboriginal, Hispanic, South Asian, Asian, and African descent, basically everyone but someone that's purely white, has an even greater risk than the usual 1 in 11 risk, so a higher risk as well. And if we are overweight, we have the genetics, then we're at higher risk. If we have a sedentary lifestyle, we're at increased risk as well. If you have high blood pressure or high cholesterol, you might have an inherited predisposition to diabetes. And as we get older, we're at increased risk as well. So these are factors that are taken into account with a risk calculator that you can find online. It's called the Canadian Diabetes Risk Questionnaire, or CanRisk. You can go to the Canadian Diabetes Association website to take the test yourself, diabetes.ca. That'll kind of give you an idea if you're at increased risk and kind of prompt you to see if you should be doing a test if you haven't had one in the last few years. So check out the CanRisk calculator. So when should you test for diabetes? Well, that's dependent on the risk that you calculate from these risk factors through CanRisk. The Canadian Diabetes Association guidelines were screening every 3 years for individuals over 40 who are at high risk for diabetes. You kind of have to go through the calculator. But if you're, as an adult, any family history, talk to your healthcare provider to see if it's time for you to do a test. And the 3 different tests that we can do to diagnose diabetes are, number 1, this hemoglobin A1C, which is a test that can be taken any time of day without fasting. The fasting glucose, which is a measure of your blood sugar after 10 hours of fasting, minimum 8 hours, but usually 10 to 12 hours. And then the glucose tolerance test that I'll talk about, that's quite more involved and requires at least a couple hours in the lab. So if the hemoglobin A1C is over 6.5%, whereas normal is closer to 5.5%, or if the fasting glucose is over 7.0, whereas normal is closer to 5.4 millimoles per liter, or the glucose tolerance test is over 7.0, or the fasting sugar is over 7.0, or after 2 hours of consuming a load of a sugary drink that tastes like a Slurpee, the number is greater than 11.1. So we often do that test to confirm diabetes. Or if someone has borderline levels for their hemoglobin A1C, the average sugar, or the fasting sugar, we might do that to see if someone has glucose intolerance or prediabetes, so that starting the proper diet or some medications early might prevent the diagnosis of full diabetes. So we can prevent diabetes by maintaining a healthy weight, reducing the abdominal fat, because that actually is fat not just on the surface, it's actually in the abdominal organs, and it's part of metabolic syndrome. It also makes our body more insulin resistant the more we have that abdominal fat. So it's not purely cosmetic, it actually affects our metabolism. And by generally eating well, like eating more frequent meals and not just having one big meal a day, and attending to the glycemic index, the ability of certain foods, especially the starchy foods, for their ability to make the sugars high. So we're going to look for ones that are less likely, foods that are less processed, and eating appropriate portions that will go into detail. And of course, regular physical activity. So people, once they're diagnosed with diabetes, there's a variety of things that we try to teach them, things that we monitor regularly. And I like to actually share the goal numbers with patients so they kind of have a goal and understand why we might be suggesting altering their treatment or the management based on the results of the lab test. So as I mentioned, it's a lot of information. So we'll be talking about that hemoglobin A1C, the average sugars that we can do without fasting. That's generally done every 3 months. The LDL and HDL cholesterol. So LDL is the one that's associated with hardening of the arteries or atherosclerosis. So we want that number to be low. And the HDL is the high density lipoprotein, or the happier cholesterol, that's associated with less hardening of the arteries. That increases with exercise, and the healthy fats, like fish oils, like olive oil, like nuts and seeds. We look at that ratio between the good and the bad cholesterol, that risk ratio. We look at protein that spills out in the urine called microalbumin, because that could tell us the health of the blood vessels and the kidneys. We monitor the blood pressure, because we have particular goal levels for people with diabetes. And we monitor the kidney function through a blood test as well. So a lot of stuff. Let's kind of take you through each of those. So that hemoglobin A1C, it's also called glycosylated hemoglobin. So it kind of gives you an idea of how much our red blood cells are carrying the blood sugars. Because a red blood cell, in general, lives for about 120 days. It gives us a reflection over the past couple of months how the glucose level has been on average. It doesn't require fasting, so it makes it kind of easier to do for diagnosis and for monitoring. And our goal with people who do have diabetes, although diagnosis requires an A1C over 6.5%, our goal to prevent most of the complications of diabetes is to keep that average blood sugar every 3 months under 7.0%, having that hemoglobin A1C under 7.0%. Now, all my patients get a bit confused of how the number for the hemoglobin A1C relates to what they see when they're checking their glucose monitor or what their fasting glucose looks like. So the A1C is actually a percentage. So that 6.5% doesn't mean a blood sugar averaging 6.5 millimoles per liter. It means a mean or average glucose of about 7.2. A hemoglobin A1C of 7.0% means that is an average glucose fasting or during the daytime around 8.1. And then really high numbers, like an A1C of 10.0%, would be blood sugars averaging 13.6. So not necessarily fasting, it could be shortly after food or a couple hours after food, the average sugar being in the teens, 13.6, which is poor control and increased risk for complications. Usually with levels like that, blood sugars in the teens, that's where you will get increased urination, extra thirst, extra hunger. So the optimal number for that hemoglobin A1C would be 7.0%, and it really reflects how the blood sugars have been averaging before and after meals over the previous 2 or 3 months. So if people are keeping their blood sugars before meals under 7.0 and keeping their sugars below 10.0 2 hours after each meal, in general, the A1C will be under 7.0%. So again, those are the optimal goals that we want when people are checking their monitor or with lab tests. So before breakfast, lunch, and dinner, we kind of aim to have the blood sugar, we can safely do that, to be 7.0 or less. And under 10.0, 2 hours after a meal. it could be a higher number immediately after taking a bite of a meal, but it's how your body manages it 2 hours later, bringing it down to 10.0. And of course, we don't use these goal numbers for people that are more frail, where they're at risk for very low blood sugars, because we have lots of medication, including insulin, that can bring those numbers down really abruptly. And we don't want the risk of being too low with hypoglycemia. And people with type 2 diabetes will not have hypoglycemia unless we give them medications that can bring the sugars down. So on to cholesterol. So LDL we typically call the bad cholesterol, but my patient kind of gave me a good way for them to remember. He calls the LDL the lousy cholesterol that you want to be lower, and the HDL the happy cholesterol. So the lousy or LDL cholesterol, we call low density lipoprotein, is bad for the arteries in general. It's usually correlated with cholesterol or plaque that clogs the arteries anywhere in the body, including the extremities to the feet, to the kidneys, to the eyes, to the heart, and to the brain. And the goal is to keep that LDL cholesterol below 2.0 for most people. And people at even higher risks, we sometimes try to get it below 1.8, which are very low numbers compared to the average, which is under 3.4 for most people. So often we need to do that with a strict low-fat diet, low in saturated fat, or we could also do it with medications, or sometimes a combination of both. Again, HDL, what my patient called the happy cholesterol, is high-density lipoprotein. That's we like that one to be higher, so greater than 0.9 millimoles in men and greater than 1.1 in women. So higher levels are correlated with a better risk ratio, and it reduces the risk for heart disease. So we could increase that by regular exercise, by eating more fish or consuming fish oils, and by exercise. Alcohol also makes the HDL go up, but there's higher risk of drinking too much, like more than 2 drinks a week raises other risks like cancer risks and liver disease and a variety of other problems related to addiction by drinking alcohol. So I don't recommend using alcohol to raise your HDL. And then the risk ratio, that's the ratio between the total cholesterol, good and bad together, divided by the good cholesterol. So we like that number to be less than 4.0. And it's kind of a measure, a rough measure of cardiovascular risk. Another test that we do at least once a year is checking the urine for traces of protein. So albumin is one type of protein, and microalbumin is looking for micro traces of this protein that can leak in the urine, and that could be an indication of early kidney damage or early damage to the blood vessels, what we call microvascular disease. The kidney gives us a good window about the overall circulation as well. And the non-lab tests that we do to monitor people with diabetes because of the increased risk for vascular disease like in strokes and heart attacks is regularly monitoring the blood pressure so that we reach a goal of 130/80, 130 being the top number when the heart contracts, systolic pressure, and 80 being that pressure when the heart relaxes, diastolic pressure. So the goal level is 130 or 80 or less. Whereas for most people without diabetes, a goal is 140/90. So we have tighter goals for patients with diabetes because of the increased risk for heart attacks and strokes, which on average is about 20%. And the GFR is a measure, a blood test that measures your kidney function. So we might indicate creatinine, but it gets converted to the estimated filtration rate for the kidney. And normal is generally over 60. So we like to monitor that because diabetes can affect that over time as well. So other things that you should consider if you have diabetes is a careful physical examination every few years to detect some of the early complications. So checking the pulse, the circulation, checking the feet. They should be examined regularly by a physician at least once a year. And we should all examine our feet every night if we have diabetes, just to make sure you don't have any infections or sores or ulcers on the feet that can get complicated. And you should have an eye examination every 1 to 2 years if you have diabetes, just because diabetes can be is one of the preventable causes for blindness, because the ophthalmologist, when he dilates your pupils, can assess if there's blood vessels that are proliferating over the light sensing area at the back of your eye. So treating those early, identifying them early, can preserve your vision for the long term. It's not the same as just checking your visual acuity like you might see with the optometrist or the opticians. So optometrists that dilate your pupils and do a careful examination with a slit lamp apparatus, or ophthalmologists, are well qualified to examine the retina of patients with diabetes. So how should you eat if you do have diabetes or pre-diabetes to prevent it? Well, we don't really want to skip meals and just have one meal at nighttime, or intermittent fasting for most of the day. So usually I don't recommend that for most of my patients with diabetes, when we want to keep their sugar levels fairly even throughout the day. We'll talk about portion sizes and the type of food we should eat. And we'll talk again more about this glycemic index that I have mentioned. So these healthy portions, you look at your dinner or lunch plate, and half that plate should be vegetables. A quarter of the plate can be the starchy foods, such as rice, potatoes, pastas, and other noodles. And when we're talking about the starches, we have to pay attention to something called glycemic index that I'll elaborate on in a moment. The other quarter of the plate would be your source of protein. So that could be lean meat like chicken breast or turkey breast without the skin, just to reduce the fat. It could be beans or tofu. It could be fish. We just have to pay attention to that cholesterol that we like to be low as well. So we try to avoid beef, lamb, and pork, which are more of the meats that are higher in saturated fats. And of course, fried foods and fast food that tends to be higher in saturated fats as well. It's fine to have one portion of fruit per meal, like one apple, or an alternative of one orange or one banana, not one of each fruit, but just one portion of fruit. If you're having berries or cherries, it would be a half cup of those berries or cherries. So one portion, so one fruit or half a cup of berries. So we don't recommend fruit juice, because to create a glass of orange juice, you're probably putting 3 oranges into the blender to get that glass of orange juice. So it's too much sugar for our bodies to metabolize with one meal. And of course, we should avoid sugar-containing drinks. So avoiding juices and pop that contain sugar, because that's going to be way more sugar than your body can metabolize after the meal, unless you're going for really vigorous exercise. So that's what it looks like. So a healthy drink could be some skim milk, or tea, or coffee without any sugar in it, or water. One portion of fruit, half the plate vegetables. The more variety, the better. And then for your grains or starches, like potato, rice, and corn or pasta, just a quarter of the plate. Again, paying attention to the glycemic index. And then a quarter of the plate would be meat and its alternatives, like vegetable sources for protein, like beans and lentils or tofu. So glycemic index. It's the ability of a food, generally a starchy food, to raise your blood sugar. So in general, we should consume low glycemic index foods in preference to high glycemic index foods. If you look at diabetes.ca, the Canadian Diabetes Association website, it has quite extensive information about glycemic index foods. And you can also find this in our Burnaby Public Library, the GI Diet. It's a really great handbook to have, because it's all not that intuitive. I'll give you some examples of high and low glycemic index food. Obviously, more processed foods generally are higher glycemic index, so we should limit those. And generally more natural foods or whole grain foods like brown rice and whole wheat bread, generally those are lower glycemic index. But there's a variety of different types of potatoes that you'd be surprised. Some are high, some are low, some are moderate in their ability to raise your blood sugars. So this type of book is really good, because it'll give you these foods that we should avoid, kind of the red light foods when we're shopping or at a restaurant. The yellow light foods would be the ones that are kind of moderate glycemic index that we should be careful about. And then the green light ones are very low in glycemic index that we can eat a little bit more liberally to take up that quarter of our plate. So some examples of low glycemic index foods that people with diabetes should eat more of in preference to the medium or high would be 100% stone ground whole wheat, more heavy mixed grain pumpernickel breads. If you're eating a cereal, it should be more like all bran or oat bran. And with grains, you want pastas and noodles that are more whole grain, or more brown rice, and sweet potatoes, yams, and a variety of legumes are lower glycemic index as well, like a variety of the beans like chickpeas and kidney beans. The kind of medium, so higher in glycemic index that we should be cautious, kind of those yellow light foods, would be generally whole wheat bread or cereal like puff wheats and oatmeal. Basmati brown rice is kind of moderate glycemic index. And newer white potatoes have a higher glycemic index than the sweet potatoes. And then popcorn is kind of in between, medium glycemic index. And then the high glycemic index, or those red light foods that we should choose less often, would be like white bagels, Kaiser rolls, white bread, bran flakes, corn flakes, Rice Krispies, the ones that have the cartoon characters and the prizes inside, and just that white short grain rice that we should avoid. And the russet potato is a higher glycemic index food. And most of the time, French fries, pretzels, rice cakes tend to raise your blood sugars more, even with the same calorie count. So that's an example of some of the intuitive and not so intuitive sources for low and healthy glycemic index foods when we're talking about the starches. Physical activity plays an important role just for our general health, cardiovascular health, our social well-being, but important for metabolism and burning off the sugars in a healthy way. So some type of physical activity doesn't even have to be exercise after each meal is helpful. So you don't want to have your biggest meal like with dinner and then just sit down in front of the couch and watch TV for a few hours before going to bed. You want to do some physical activity, even if that's doing a little bit of sweeping or vacuuming or just some floor exercises in your home. In the summertime, people like to go for a walk. And if you live in a well-lit neighborhood and it's not too wet, or you have good rain boots and bright colored rain jackets and umbrellas, then a walk after a meal with your loved ones and with your family in a healthy environment would be a good way to end the evening and to burn off some of that sugar from that meal. So the general guideline is to work up to 150 minutes of exercise per week. On average, that would be like 30 minutes, 5 days out of the week. But you certainly could break it up to the little 15-minute walks, 15-minute bouts of exercise a couple times a day for most days out of the week. And walking is always a good gateway exercise for all of us. So any kind of physical activity would be great after each meal, breakfast, lunch, and dinner. Don't just lie down and take a nap after a big meal. So just some general tips on achieving your goals. Because when I talk to my patients with diabetes, we talk about what their goals are for the next visit. And it might be kind of tweaking the diet to improve the cholesterol to get to that goal of under 2.0 and some people under 1.8 for the LDL. It might be improving the sugars after meals to get the glucometers under 10.0 2 hours after meal. It might be, so that could be increasing, doing a little bit more exercise. It could be eating healthier food, like more lower glycemic index foods, or reducing the sugary things in their diet. So it's really important that we can offer suggestions for a goal, but it really is important that it's a goal that matters to the individual patient, that's important to them, to kind of connect those two together to keep them healthier and to have good reasons of why they want to do that. Because if it's not a goal that you really want to do or you're motivated to do, then we have to pick something that has a bigger impact that really resonates with you. It's really important to visualize yourself achieving that goal. So to see yourself in the next 3 months, improving your numbers because you've adopted this new change. So seeing yourself achieving that goal in the short term. So you really want to make it a manageable goal that you're going to feel proud of because that will increase your confidence. So I want you to see the change that you wish to be. And those bigger goals, we want to break down. So if you're not doing any exercise right now, but you want to work up to that 150 minutes a week, I wouldn't suggest that you go out and start running 30 minutes tomorrow and try to do that for 5 days. out of the week. If you're not doing all that exercise, then you would start with something that's really manageable that for sure you know that you can do. Because once you achieve that smaller goal of just going for a 15-minute walk in the morning tomorrow and see if you have some extra energy and reserve to do another 15 minutes later that day, or making just a goal of going out and walking for a certain number of minutes every other day to start with, and then building upon that as you gain your confidence. So we start with things that are really manageable and then add on to those week by week, and then you'd be surprised what you can achieve when you see your doctor again. If we write down our goals, simply writing down our goals has a big, huge difference in making us more successful. It helps us remember things, and it's just that connection, that hand to the paper connection that really drives things down, and we can see our goals and we can put it up to remind ourselves. And to make it even more likely you can succeed, and kind of share that with people that you live with or with your friends. So this is a little acronym to remember some of the key things that we should think about if we're setting a goal to improve a few things in our diet or to increase our physical activity. So one, our goal has to be really specific. It's not just I'm going to exercise more, but specifically what exercise am I going to do? M means measurable. So how much, how far am I going to walk, or where am I going to be walking, and what distance in how many minutes? Achievable means it has to be broken down into something that I can reasonably do. A little bit of challenge, but not overwhelming or daunting. Otherwise, I might just procrastinate, or I'll try to do too much, get injured, and then give up. R means it has to be relevant. As I mentioned, it has to be important to you and your health. And T is the time frame. When you're going to start, when you're going to finish. E is for when are you going to review things, like after a week or 2 weeks, and assess how you've done, what you've learned, how you're going to ramp up or ramp down your goal for the next week. And then S is for stepping forward. What am I going to do next? How will I do it differently? And who am I going to invite to do this with together? So who can I share my success with, or who can I invite so that I'll be even more successful? So SMARTest goals, just a little acronym to remember the key things to make it a really doable, realistic goal that's relevant to you. We should anticipate and prepare for roadblocks. So I just had foot surgery 4 weeks ago, so I just started walking this week. So I've been out of the pool, out of the gym for over a month now. So I'm really keen on getting back in the next week, but I know I'm not going to be swimming an hour front crawl every single day in the next week, or even twice a day, although I'd like to do that. And I know that there might be obstacles. It might, my foot might be really sore and I might not be able to do that every day. So I should kind of prepare for that, probably set a smaller goal and see how things are going and come up with an alternative plan if there's some obstacles or problems, and alternative exercise if I can't get into the pool. And of course, when we do it with others, we'll be more successful. So supporting others, sharing our goal, doing that goal with people around us, or talking to your primary care provider, your family doctor, to help you craft a goal or to anticipate any roadblocks, or because we have a lot of resources for people that are interested in working on improving their lifestyle. We actually have coaching through our primary care network. So those of you who have a family doctor in Burnaby, they belong to a primary care network, and then by default, you belong to that primary care network. And we have some lifestyle coaching that's available. So your family doctor in Burnaby can refer you to coaching if you have a lifestyle change you'd like to do, like improving your diet or starting some exercise. Then just talk to your family doctor about the PCN resources for helping you achieve your goals. And also recently, my patient asked if he could go to this program. So this is for people that are super motivated to get their diabetes under control. So this Lifestyle RX is a group of doctors, internal medicine specialists that are expert in diabetes, and family doctors with special interest in diabetes. So they have this 12-week program, which is totally online, to coach people that are really motivated to kind of improve all their numbers that we talked about. So this is a well-known program that doesn't cost anything, kind of is covered by MSP. So So if you're really motivated, if you're newly diagnosed, or if you have diabetes and you'd like some expert coaching and support for kind of reversing and improving your numbers, this is a great program to connect with as well that doesn't cost anything to you. So back to your positive potential. I believe that every one of us, everyone here, and everyone in our lives has a unique positive potential in life. And it's our duty to recognize and work towards our own potential and to help everyone around us achieve theirs. And that's a big part of why Leon and I are here, because we want all the people that we can touch to get the most out of their lives, to achieve their goals, and to have their happiest, healthiest life. And with knowledge, engagement, and support, we can manage chronic health conditions and live well. And just to make sure you don't feel alone, every one of us, everyone in our virtual room has the same chronic condition, not diabetes. It's incurable, it's sexually transmitted, and it has 100% mortality. And you probably know it's a 4-letter word. That condition is called life. And we can still make the most of it, and it's still worthwhile. And your life is a work in progress, but it's really a beautiful work of art as well. But we all kind of share as the artists and authors of our own life, but we can't do it alone. So I'd like you to share anything of value that you've learned. I hope there has been some resources that you can share with the people you care about. And if you know someone that has diabetes, please share this with them. And also the resources of the Canadian Diabetes Association or Lifestyle RX, or the resources of our primary care network with the health coaching. There's so many resources, and we're all here to support you so that you can be your best self with the best health. So we're all expanding our circle of caring to care for the future of everyone in our community and for the best present for yourself. So remember to pass that on. Healthcare is self-care. I hope there's some questions that I would like to hear from the audience. It's hard to do things virtually because I don't get to see your lovely faces and to hear your questions in person.
We do have some questions. So Anne was asking, what can I do if my hubby, who is diabetic, eats mostly starting in the evening, maybe dinner and lots of snacks? His snacks include scones, cookies, chocolates, chips, and candies. Yum.
Mm. First, you have to accept them and to have a talk about, does he have all the information he needs about managing the diabetes? To talk about what's most important to him, what his most important values are. Of course, most important to him would be for his wife to be happy. Happy wife, happy life. But we want to make it in a positive way. So the goals that we set. So I learned early in practice that doctor's orders are not followed. And when a patient doesn't follow the orders or doesn't start exercising, doesn't quit smoking when I see them again after I told them 3 months ago, it's not the patient's fault. It's actually my fault for not listening to the patient. So I obviously was not listening what mattered to them, or I didn't work with them to set kind of a realistic goal that's attuned to what they would like to do. Sometimes it's knowledge, because a lot of people think diabetes is just about sugar, it's just a number, or that my parent had diabetes, my grandparent had diabetes, they all died young, so I'm going to expect of myself I have nothing I can do about it. But that extra knowledge, knowing that little things like the type of foods we're eating, how we're eating, physical activity, that we can have control even if we have that diagnosis, and we can change the trajectory of our health. We don't have to have the same complications that our parents had. So that knowledge or sharing this talk with him, and or enrolling in Lifestyle RX, can really empower people to make positive changes in their lives so that they don't give up. But knowledge is the first one, but also connecting each goal to what is the most important to that individual, to your husband. I hope that helps. That's a good starting point, I think.
That was great. That was really great. Somebody asked, what A1C range is pre-diabetic?
Well, pre-diabetes is anything that's above the normal level. but the numbers have changed a bit. So the number for diagnosing diabetes changed from the time I started practice. We used to say it was 7.8, and then went down to 7.0. So you'll see when you see your lab results for A1C or the fasting glucose, it might look red, but it's actually nowhere close to diabetes. So when it gets into the 6.0% and starts to creep up, we would consider that to be pre-diabetes for most people. But what I do if I see a fasting glucose that's above the normal of 5.6, like 5.8 or 5.9, and I might see the A1C kind of on the borderline of normal, but not close to diabetes. I look at the pattern of the patient and we look at it regularly to see if it seems to be going up or trending up. For a lot of patients, it doesn't trend anywhere, it just stays the same, like for 10 years and never becomes diabetes. So the extra thing we can do to see if that person has the potential for diabetes is doing that glucose tolerance test. So it takes 2 hours, but it's probably worthwhile doing because that'll tell us with that extra load of sugar, if 2 hours later the blood sugar is not quite diabetes, but a number a bit below that, but higher than 7.8, then that tells us that this person has the gene for diabetes, that interventions we do now can help prevent diabetes. So it's a combination of those two. So any hemoglobin A1C that's above the normal or fasting blood sugar above the normal should prompt us to talk about the 2-hour glucose tolerance test. And that can reveal if we're at that stage that we need to intervene with medications or diet.
That's great. Great. Thank you. Marcella, hi Marcella, asked how to register for the free Lifestyle RX program. I just popped the link to that site in the chat so people can access that information from there. I have a question here from Craig says, Indigenous Services Canada says First Nations on reserve have a rate of diabetes 3 to 5 times higher than that of other Canadians. Rates of diabetes among the Inuit are expected to rise significantly in the future, given that risk factors such as obesity, physical inactivity, and unhealthy eating patterns are high. Your thoughts on this horrible statistic, and have you found this big discrepancy to be the case amongst the urban res or First Nations who live in the urban centers like Greater Vancouver area?
Yeah, so that's genetic risk. And as I mentioned, people with pretty well every ethnic background, including Aboriginal, Asian, Southeast Asian, pretty well everyone that, other than someone that's totally white, has an increased risk for diabetes. And then that combined with how we're eating. So if we're eating too many calories or high glycemic index food, like if you just watch TV for the next 2 hours instead of watching this, you'll see like 5 or 6 huge hamburgers. There'll be probably multiple. It'll be Burger King, McDonald's, and Wendy's that'll be advertising these juicy hamburgers. And pretty well everything you get at McDonald's and Wendy's and Burger King is going to be high fat, high glycemic index. Those French fries, the pop, and you won't be able to burn that off no matter how far you walk after having that meal. So that increase in that diet, in the increased calories, increased glycemic index of the food, the high fat foods is going to lead to increased abdominal obesity in the people that have the genes for diabetes to start with. And that's why it's become an epidemic in across the world, and particularly in people in particular ethnic groups, pretty well all ethnic groups, except for all white. But even then, it's still about a 10% risk, and much higher, as you mentioned, 3 or 4 times higher in ethnic groups with that genetics plus with that Western lifestyle and the diet that we consume.
Right. Excellent. And there's another question here. Can we reduce the level of bad cholesterol level through blood donation or plasma donation?
No. Actually, had one patient that had very high levels of triglycerides and LDL, and he said, and after that, I told him how bad it was. It was like your blood was like cream. The lab described it as like cream. And he said, "Can I donate blood?" And I said, "Well, you could, but you might give somebody a heart attack." But it actually doesn't lower your percentage of that. It might make you a little bit more anemic, but it doesn't thin out your blood and take away that cholesterol. So we usually do that with diet and if necessary with medication. But just donating the blood is really only helpful in one condition where people have an iron storage disease, where they have hemochromatosis or really high iron levels. And then they actually donate blood regularly, and that's healthy blood to donate to other people. That's lots of hemoglobin in it, lots of iron. So it's good for someone that's in need of blood. And then that's probably the only therapeutic thing with doing blood donation.
Okay, great. So someone has said, my grandmother has diabetes, my mom does not. Would I get that without me knowing? And then she says, if I'm sad, I realize I eat too many cookies and drink Coke at midnight on several evenings. Would that give me diabetes from doing that?
If you happen to have the gene for diabetes, that could be from either side of the family. Some of my patients that we diagnosed with diabetes will say, like, neither my mother or father had diabetes, but it could be if they had died from some other cause at a young age. It could be they weren't tested for diabetes, or it could be the old way we test for diabetes was with much higher numbers than we measure today to diagnose diabetes. There's been a slide and a reduction in the number that we consider normal and the number that we consider for diabetes. So it could have been they may not have been diagnosed or they're not being
Right.
tested, so they don't know. So it is still possible. But it is worthwhile if you've been eating those foods and you haven't seen your doctor lately to talk about should you be checking your cholesterol or blood sugar. It's probably worthwhile talking to your doctor to see if we could do some testing to see if it's time to check for diabetes, check the cholesterol, check your blood pressure.
Right. It's good advice for everybody, myself included. A question, general thoughts on metformin and other common diabetes medications, common side effects? Question mark.
The most common side effect with metformin is it's generally for most people, it's our first line medication for diabetes because it addresses that glucose intolerance, our body's sensitivity to its own insulin. So it actually helps us metabolize sugars better, helps us use our insulin better. Metformin's common side effects, though, if we go to the full dose right off the bat, people will get diarrhea, gas, and bloating.
Mm.
So for informed consent, we always tell our patients, start really slow, take it with meals, we're going to start a really low dose, like half a tablet with one meal, make sure that's going down okay. And then the next week we get another half tablet, do it really slowly. And of course, the other informed consent is you inform your spouse that you might be having more gas as well.
Good call. Excellent. That's it. Does anybody else have any questions? I think that's all the ones I've got here. Really nice comments. Thank you. Oh, here we go. A late friend of mine had diabetes type 2 and it made everything involving his health worse. Everything. Have you found diabetes can serve as an amplifier or early alert system of regular medical conditions before a person would normally note something is wrong?
As I mentioned, we can diagnose diabetes before someone has any of those classical symptoms or complications. And so it's looking at your own risk factors. And as we get older, usually by the time we're 40, you should have a conversation with your doctor what screening tests you should be doing. There's a variety that we should be doing. And then using something like the CAN risk calculator, your doctor can determine if you're at increased risk and maybe you should be tested. Because all the screening tests we do are for detecting things before we have symptoms. So we can catch things really early, or where intervention, lifestyle changes, and sometimes medications could make a huge difference in avoiding more serious disease.
I'm just putting the screening tests document into the chat so people can take a look at it. And that covers all the questions, unless somebody wants to put a quick one in there. There we go.
Okay, and the screening tests and symptoms to watch out for is a recent talk that we did. So you can find the video from that recent talk on the Empowering Patients website, and also the slides and the handouts as well.
Right, for sure, for sure. I think that does it. Some thank yous in the chat. Thank you for that. If you don't have anything else you want to comment about, remember to sign up for December 19th. If you're going to be hanging out with your family over the holidays, maybe you just want to do a little, participate in a talk on emotional wellness. Couldn't hurt. So yeah, we'd love to see you there right before Christmas.
Yeah, I'll be sharing what I think are the kind of the fundamental emotional well-being skills that we should all be learning in school and teaching to our kids and mastering as kids and into adulthood as well. So important to have those, not just to treat mental illness or when we're really blue, but just to remain really happy and engaged and joyful and peaceful in life and feeling really connected to people around you, feeling part of a big community. So that's the goal, is the well-being, not necessarily to treat the blues, but Christmas
Right.
is a time with really mixed emotions. Lots of
Yeah,
joy, but a lot of sadness. We missed our loved ones. If we can't be with all the people we love, is really sad.
that's right.
And some
That's right.
people are,
I always look forward to that. I look forward to all of them, but I do really look forward to that one, especially that time of the year. I'm really glad that we do that one at this time of the year because it can be a really challenging time for people. So excellent. Well, I think you did it. 14 minutes to spare.
oh, okay, I should do one more informed consent. So
Okay.
any of my patients that are out there, when you come to my office, you're going to hear continuous Christmas music because all the medical office assistants asked for Christmas music. So I brought in my iPod that's layered and loaded with thousands of hours of Christmas music. So everything from Rudolph to Rocking Around the Christmas Tree, and every Christmas song, every version that you can hear, you'll be hearing that continuously.
That's great. I'll have to come by and visit.
Yeah, anytime.
Excellent. All right. Well, thank you so much. And just remember, when I end this session tonight, there will be a quick evaluation. Dr. Wong and I look at all of your comments, good, bad, and different. So if you can take a moment to fill it out, that would be great. Thank you so much. Thank you, Dr. Wong, as always.
And
It's a
thanks,
pleasure.
Leona. And thank you all for attending, and thanks for all your kind words and nice messages as well.
Excellent. Thanks. Good night, everybody.
Good night.
Good night.